Thank you, Christian, and thank you, Nina. And we have seen more participants this year than we had our ethics workshop last year, which is very encouraging. So what I'm going to do is to give you some few medico-legal perspectives, medico-legal cases, particularly one which has been in the headlines in the UK and worldwide. So I will bear with me because there are 3 or 4 slides in detail about what exactly happened with that case. You have seen these sort of news headlines more and more about the doctors or physicians who actually perform FGM has been charged or has been arrested. And this is only a couple of weeks ago. This is about a prominent FGM campaigner. She's a specialist midwife. She's in the news. It's nothing to do with the FGM, but it was some questions about her qualification. But she was a pioneer in the UK about setting up the FGM clinics. And so you always, when you see these sort of people who have been prominent in a particular area, have been sort of targeted, you always think, is there a hidden agenda behind it? So it's all the things to think about. So what I'm going to show you is this particular case. This was actually came up to the sort of a public in January 2015. The story is this. So a woman, for the legal reasons, known as AB, presented into labor in a hospital in London at about 8 a.m. in November 2012. That was her first child, and her labor was progressing fast. And at about 10 o'clock in the morning, Dr. D, who is the doctor concerned, called, and he was on-call obstetric registrar, who is the junior ONG trainee, was believed to come to the delivery room. I'm sure, just to give you a rough idea about what happens in the UK, most of the time the midwife will look after the straightforward deliveries, and they will call the trainee or the obstetrician if there is a problem. So this doctor was called because there was a delay in progress. So until that point, the doctor has never seen the woman who had undergone FGM and had never been given training on the subject at his undergraduate or postgraduate studies, and had no experience of how to carry out a de-infibulation procedure to help women have undergone FGM to give birth safely. So basically, this doctor was there, he was called, and he was just literally handed over this patient. And he was handed over the mother's notes, which the midwife has stated that she was presenting with type 1 or type 2 FGM. So all the hospitals in the UK, the policy is that mother should have been picked up by antenatal teams much earlier in her care. We will come to that in a minute with the guidelines, in order to be seen by a specialist team and referred for a de-infibulation procedure months before the delivery. But of course, this patient was missed and didn't have that kind of care antenatally. But the midwives have failed to pick up her condition, and instead the doctor had to intervene surgically within minutes, with the birth progressing fast and the baby showing signs of distress. So the fetal heart was dropping, and there was an indication to do an instrumental delivery. So to put a catheter, so he was trying to put a catheter because he couldn't find the urethra. So what he did was, so this is his statement in the courts. So it was in the second stage of labor. She was already 10 centimeters dilated. There was a band of scar tissue that was obstructing her urethra. I obtained her consent to make a cut and made an anterior midline cut. And he said that expectant mothers appear anxious after coming into labor ward and finding herself in an emergency situation facing the instrumental delivery. It's not a surprise. The doctor added that he made a single cut measuring 1.5 to 2 centimeters. During the delivery with a suction cup, he made another cut, obviously episiotomy, commonly carried out in childbirth to allow baby's head and shoulders to be delivered. So within 40 minutes of arriving in the labor ward, he safely delivered the baby boy. The cut was still bleeding. So this was his comments in the court proceeding. So that's why it's somewhat in layman's term. It had continually bled since the time we made it and during the delivery. I decided to place a suture to stop the bleeding. I placed a single continuous suture in a figure of 8. I was acting in the patient's best interest to stop the bleeding, he said in evidence. It took about 30 seconds, and immediately afterward, doctor was called away to carry out an emergency cesarean section. Right. So it was while he was in the theatre, he began to doubt the procedure he had carried out. He spoke to the consultant on duty, who advised him that the technique he had used was incorrect, but that he should leave the stitch in. The hospital policy, that particular hospital where African Well Women Clinic treats about 130 women per year who have undergone FGM, dictates that the labia should never be stitched together during such repair, because that would amount to reinfibulation or restoration of the FGM. But Dr. D admitted that he had not read hospital policy and realized that what he has done was incorrect. I should not have stitched it with the technique that I used, he said in the court. Now I am well aware of the correct surgical technique. So after the incident, so this happens, and then hospital inquiry examined what had taken place, labeling the event as what we call the serious untoward incident. So that means what we call the never event. This shouldn't have never happened. And the inquiry recommended, so these are internal, so this is happening within the hospital. Inquiry recommended more training for the doctor and period of reflection. 5 months after the incident, so he progressed and he was made a senior registrar. So the hospital has referred what has taken place in the delivery room to the Metropolitan Police as a matter of course because of its concern. So it's not very clear where the concerns were, whether it is from the patient or whether it is from the midwife or whether it is from someone else. Then the referral come at a time of growing public and political pressure on the police and the prosecutors over their failure to bring a single prosecution of FGM in the UK since it was made illegal in 1985. Legislation that subsequently toughened in 2003. So in May 2013, this 5 months after woman has given birth, the police passed that information. So what happens is obviously if the police get some information about a possible crime, they have to pass it to what we call the Crown Prosecution Service, that's the solicitors or attorneys or prosecutors for guidance. So it was one of the handful cases passed to the CPS for consideration. In March 2014, that's 16 months after the baby was born, the CPS announced that Dr. D and another man was actually who's that woman's husband. They are going to be charged in a landmark prosecution. So that's that headlines. They made the charges public 3 days before the director of Crown Prosecution Service was appeared before the Home Affairs Select Committee. That's in the Parliament. They have like select committees. To be questioned over her failure to bring a single prosecution for the FGM. So this just to give you a background information, not just that particular incident. Okay, so this is in the courts. The prosecution said that he has re-stitched the labia together after birth, thereby performing FGM. If you look at the legal aspect, which is correct. So if you re-infibulate, considered as FGM, because we will come to that in a minute. But Dr. D said he only put a small suture at the top of the cut to stop bleeding. That's his argument. It is that stitch back together by D and the woman's husband's insistence or encouragement which the prosecution says is an offense under the Act. So it's not only just putting the stitch, the woman's husband, apparently who was there, has insisted that he put a stitch. So these are all what we know. So we don't know actually what has happened. So then the prosecution is the result of an alleged offense under the Female Genital Mutilation Act 2003. So what Dr. D did was against the policy of his employer. We all know that, so he shouldn't have done that. The policy is written and available to all midwives, nurses, obstetricians, and students at that hospital, and Dr. D was expected to be aware of that. So not aware of the law is not an excuse. So we all have to be aware of the what is the law. Right, so these are the headlines. A few days later, NHS doctor cleared in less than 30 minutes in the first FGM case. The judge took only 30 minutes to find him that he is innocent. The judge's point was The doctor, who was a junior registrar at the time of he delivered the baby, said that he had received no medical training in the FGM, had never seen a patient with FGM before. Right? He also have never observed a deinfibulation, a procedure for reopen a woman who has undergone FGM. But he accepted in hindsight he should have sutured the edges of the cut separately rather than sewing together, in line with the hospital's FGM guidelines. So Justice said he has been badly let down by systematic failure at the hospital, and he was not referred, the patient was not referred to an FGM specialty during the antenatal appointments and was not given a birth plan or interpreter. So this is from the beginning to the end of that particular story. Right. So, so this actually has created a lot of anxiety, a lot of statements, a lot of issues, a lot of discussion amongst the obstetricians in the UK. In fact, Royal College of Obstetricians and Gynecologists had made a separate statement with effect to say that the doctor has been badly let down by the system. So, the questions. So, was it the correct decision to prosecute that doctor for FGM and reinfibulation? Any thoughts? Christina. Yes. I mean, this is not my personal views. I'm just going to give you the presentation, and let's discuss what is right and what is wrong and what should have been done.
Okay. Well, I'm Bria Pothoven from Holland. And I think it's right to prosecute the doctor, because then you can see what's going wrong in the system. Yeah, absolutely. So, any ideas for or against? So, this lady says that it is right to prosecute him until we get to know the facts.
But I'm Svetlana. I'm one of the Urogyn Fellows at the University of Chicago. I don't think example of him being prosecuted is example of the registrar on call who is trying to manage whatever is there. So number one, it's a failure of system, because there should be records and antepartum visits that say this is a patient with female genital mutilation, that we discussed what she wants. Because all of this, like I have encountered patients who had female genital mutilation that say, if certain things rip, please stitch back. You know, we have had ethics involved in a hospital, so where is that part of the discussion? And him as a registrar, or like in States we call it a resident, who is running between 77 delivery rooms, Absolutely. You know, trying, it's not excuse, it's just cheap excuse, but still it just shows that the system has failed.
Absolutely. That is the reason why he was found. It is because of a failure in the system.
Hi, Tracy Wilson from Alabama in the United States. I question, what is the policy if the patient is bleeding? And, you know, because his reasoning for placing the stitch was not to do the reinfibulation, but to stop the bleeding.
Exactly.
So what's in the policy?
Yes, there are a few slides.
Handling bleeding?
There are a few slides coming up to show the technique of deinfibulation, which has been in the RCOG guidelines, which clearly shows. I'm just going to show that pictures after the discussion to show that you can always, rather than closing, you have to suture separately on the divided parts. There are a few images on that.
I was just going to ask where the staff member was, because this registrar, this patient's not under this registrar's name. So I was wondering if the staff physician was ever called, if the resident had time to call the staff doctor to ask to run this by him, because technically the staff should also be dragged into all of this, whether it's fair or not. I mean, his name is assigned to that patient.
Yeah, in fact, what actually happened was he was the registrar on call. I think he was like you mentioned. I mean, like all of when we as registrars, so we're running around the labor ward, and then if something major happens, then you inform the consultant or the specialist. I think he informed the consultant afterwards, and then he was told that what he did was wrong, and obviously, but you shouldn't so remove the stitches. So that was the information which was given to him.
Very nice presentation. My name is Hasiba Hamoud from UK, urogynecologist. I actually deal with female GFM, but it looks like she had already FGM. This
Yes,
situation.
exactly.
And he hadn't done anything wrong. He just put her back because bleeding. So he did not did the FGM for her, but he instated because of the bleeding. He had no experience of what he's going to do, and it is a teamwork. Should be midwife, should be other assistant or consultant to know, and the system, as it says here.
Exactly. It is the, unfortunately, I didn't go into the details, but there was one place it's mentioned that one stitch made that registrar's life hell. Because what he should have done is, rather than just putting one figure of 8 stitch, he should have put the stitches on either side after he opened. But there are a couple of slides to show that. So, this is just to highlight that what sort of a political pressure. It's simply because if you look at the facts and everything, it looks like there's a lot of political pressure as well. And then so there's always a lot. So that's the main reason why the judge dismissed this case within 30 minutes. Well, according to the, it's not the patient, it's not the patient's husband. Actually, it was the midwife. Yeah, because the midwife was attending the delivery, because I think that midwife's looking after the patient, and then he called the doctor to, put the stitches. And then what the midwife has done is, midwife has said that, he has put the stitch, which is by definition FGM. Yeah. Exactly. Absolutely. Yeah. So because we have limited time, so what I'm going to move forward, just to give you a rough idea about the law with regards to the FGM. So these are the countries by law, it bans the FGM. Okay. So if you look at the numbers, quite a few African nations and a few industrial nations as well. So I'm not going to go through the list. And but especially, it's interesting to find that the countries which the FGM is prevalent, like African countries, including Egypt, Ghana, Senegal, Sierra Leone, so all these countries have made it illegal. And in the UK, I will just quickly go through, because this is the UK law. So basically what it says is FGM is illegal unless a surgical operation is on a girl or a woman, irrespective of her age, which is necessary for her physical or mental health. She's at any stage of labor or just given birth for purpose connected with the labor of birth. It is illegal to arrange or assist in arranging for UK national or UK resident to be taken overseas for the purpose of the FGM. So it's an offense for those with parental responsibility to fail to protect the girl from risk of FGM. But the important one is the last sentence, especially for this particular case which I just mentioned. Reinfibulation is illegal. There is no clinical justification for reinfibulation, and it should not be undertaken at any circumstance. So that was the legal point he was prosecuted on. So this RCO... Sorry, Nina.
No, but this is something, when I was going over these slides, I didn't see this, that female genital cosmetic surgery may be prohibited against as necessary. So is this cosmetic for her? I think that's something we're going to get to. Tamara's discussing that. But I think that's an important distinction to make, is what constitutes, is this genetic, is it
if you deliver a baby, his first responsibility is to the woman to deliver her baby safely without harming her or the baby.
Absolutely.
And to make sure she doesn't bleed out. So to me, he did his job. You know, the reinfibulation problem was, you know, is one stitch really, was that reinfibulation
Exactly.
either?
Yeah.
I don't think he did that. I'm sure she was still open
Yeah.
at that point. Thank you.
And so this is the RCOG guidelines. It's very clear about the reinfibulation. That's why I thought I will just show you this. So this is like, you know, type 3, sort of, this is infibulation. So this clearly shows you how to deinfibulate. So infiltrate the midline scar with local anesthetic. Yeah. And then you keep your finger underneath, or maybe you can use the pair of scissors, open pair of scissors, so it comes as a guard between the urethra and the skin, and then you divide it. This is the most important thing. So this is how it should be done. So this is what the recommendation is, because we actually don't know how big that cut was, whether it was possible to do this sort of deinfibulation. So these are the technical aspects, and these are the areas which we really don't know. So this is what's recommended. So by doing this, you're not closing it again. So you're just leaving it open, but at the same time you just control the bleeding. So this is what the recommendations. And so this is an example, and these are the actual the diagrams from the RCOG guidelines, so which is very clear. So just to close my presentation, I'm just going to give you this like a flow chart for the plan of care for women with FGM in pregnancy. This is the RCOG guidelines. And so obviously early recognition, or especially particular ethnic groups, you have to suspect, and then you have to recognize, and then you refer them to designated midwife or obstetrician with responsibility for FGM. This is what most of the places they have. And it should be a consultant-led or specialist-led care. So child safeguarding risk, because if it's a baby girl, the girl also have a risk. Then the data recording, this is H, that's Health and Social Care Information Committee. So where they have their data set, so they get all the information from all the places. So inform them, so they document the diagnosis, what type, and then the clinical management plan, clear documentation. So antenatal, so use professional interpreter if there is association, if there is any kind of language barrier. Offer the referral for psychological assessments, screening for hepatitis, and additional antenatal screening. Make clinical assessment of the FGM. If the deinfibulation is required, agree timing and explain that reinfibulation will not be performed. And then normally it is recommended that if you recognize this, deinfibulation should be done well before the delivery. Yeah. And obviously, I said the obstetric risk factors, agree document plan. And intrapartum, generally managed as high-risk cesarean section. And some women who are, because just imagine, when it comes to this point, they have recognized, they have deinfibulate, and so there is no issue about it. But unfortunately, this particular case which I discussed missed all this, and then suddenly poor registrar who was on the labor ward, it could have been you, it could have been me, and then if he don't know the law, so this poor guy just put a stitch, and then the interesting question is sort of who reported, and then there's a lot of sort of a discussion from that aspect. Again, then the postpartum, so these have to be documented, and then the child sort of protection issues, and offer postnatal follow-up if deinfibulation performed intrapartum, or if planned, deinfibulation did not occur, make sure that all the data has been recorded. So it's good that we have created a lot of discussion around this area, and so just it shows that how contentious these issues are.
Can I just say, another thing that's involved in, thank you. Another thing that's involved in this is the issue of consent. And you can't get consent. I don't know how it is in UK, but I think pretty much everywhere you can't get consent when somebody's already under anesthesia.
Yeah.
And So I think that on several levels you need to look at this from an ethical standpoint. As far as the way the registrar managed it, I think you have to say it was appropriate, even though it was against hospital policy, that the patient
Absolutely.
had been managed properly from day one, so
Yes.
there was no way that she could be managed properly. That
Yes.
all had to be decided beforehand. So I think it's important because we're talking also about choice throughout this, the choice of having FGM done.
Yes.
And the choice of having defibrillation, and then the choice later on of having genital surgery, and what are the indications for that?
Yeah.
Okay, so everybody's supposed to think about that.
Yeah, so my question is, if I don't like the way my labia look, I can go change it. And so in some ways, I wonder if we're taking choice away from this woman saying she can never be reinfibulated, because she became sexually active with her labia looking a certain way.
Yeah.
And although I'm very much against FGM, as you all know, but if she wants to be reinfibulated, can she make a case to court that that's important for her mental health? And how do we
Exactly.
now preserve her choice all these years later when it was originally not given to her?
That's right. From the legal point of view, if there is issue with the psychological state, or I mean, we sometimes I fully agree with you, Alice, because it is the woman's sort of choice and the right. For instance, similar to have a C-section, cesarean section. Recently, there's been one government ruling. There is again legal sort of ruling to say that as far as the patient's been rightly informed, even though there is no clinical indication, patient has a right to choose for a cesarean section. So based on that, you can always argue. So I think in a way, are we going to sort of always debate whether we are sort of medicalizing, or we are taking the woman's right to, the right to have them like how it looks like. And sometimes, obviously, there are places, if the woman is sort of rich enough, they can go to like a private clinic, and then they can get whatever the cosmetic surgery they do.
Yeah, but also I think as a doctors we have an oath, and reinfibulation is not in patient best interest, and it goes against the non-maleficence principle. So even if we may be taking patient choice to be reinfibulated, we should not agree to do it, because as a clinician we know it's not in the best interest, so we'll be going against our oath. That's my perspective.
Yes, there's a lot of things to discuss.
The postpartum care was over or done, and the patient develops a situation when she needs physical therapy for incontinence or constipation, pain. And what if within that time, when she's sent to me, I see that she is sewed up again? Who do I call? Social workers, police, the doctor? Who do I report? In UK, for example.
Yeah, I think in the UK, because this is from the medical legal point of view, because you cannot prove, unless there is a documentation that this patient has been reinfibulated. If there is a documentation, yes, this patient had during the delivery, she was deinfibulated and then reinfibulated, stitched back again. If somebody can prove it, then if you complain, you can either complain through the hospital, or you can complain to I think this is what happens. So that the hospital inform the police, because the police has to make a case to see whether this can be prosecuted. So I mean that's where the question is: can you prove that she has been reinfibulated? And then the question is whether, if the patient requested it. But if the patient said, yes, I didn't want to have that, but somebody stitched me up, then yes, there is a case.
I think in that kind of a case, though, I mean, if it's inhibiting physical therapy, you have to talk to the patient
Absolutely.
I mean, because I think, again, your first responsibility is to the patient. If she wants to remain that way and it's a problem, then you have to discuss it with her as to whether or not she would want to have something done to allow you access to the area, but she may not want that.
Yeah.
If the record is so that she has been sewn separately,
Yes.
as it should be, and we remark, okay, it's closed again.
Yeah. So that then, I mean, like Nina said, I think at the end of the day, if the patient doesn't want it to be like that, then you can always make a case. So this was done, and there are two aspects. So whether you want to go on the legal side or whether you want to help the patient. If the patient says, I've been restitched, I want it to be opened up, then you refer to the appropriate physician, so which you can do. But if the patient says, no, I don't want to do anything, then that's the end of the story.